Good afternoon, everyone. My name is Maya Luria with TMC for Seniors. And today, I'm not sure if everyone is aware, but it is actually colorectal month. And we're going to be having a talk called Behind the Scenes, the Bottom Line on Colorectal Screenings. Dr. Peter Lee is here with us. He is with Arizona Oncology, and I want to share a little bit about Dr. Lee's background. He is a board certified general colon and rectal surgery with Arizona of the colon, rectum, and specializes in minimally invasive or robotic assisted procedures for benign and malignant diseases in those areas. Dr. Lee has been published in several medical publications, presented to the New Jersey Society of Colon and Rectal Surgeons and the Academic Surgical Congress, and was named an American College of Surgeons Fellow in 2016. He is a current member of the American Society of Colon and Rectal Surgeons. His priority is to provide expert surgical care that is both comprehensive and compassionate. Welcome, Dr. Lee. We're so happy to have you here with us today.
Thank you for having me, Maya. Thank you for that nice introduction. Yes, I can hear you.
Yeah.
Everybody. Okay. So my name is Peter Lee. I'm a colorectal surgeon, Arizona Oncology, and I do basically all my work here at TMC. So it was a pleasure to invite me to give this talk, Bottoms Up, Behind the Scenes, the bottom line of colorectal screenings. And as Maya had said, this is Colorectal Cancer Awareness Month, and I'm glad that we have a month to ourselves because colon cancer is one of those things that affects Americans profoundly. And I'll go into some of those details in a little bit. So we'll get started. So I will go over a couple of things. First thing is the importance of colon and rectal health. We will go over the current guidelines for screening for colon cancer and go over some prevention and risk factors that people may get when thinking about colon cancers. The short is actually not that long because I want to reserve most of my time for any questions you guys have. So if you can write them down at the end, we'll be happy to take every one of them. Who knows who this guy is? Okay, so this dates me because I remember who this guy is. So one of his famous lines is "no respect," and the reason I say that is because colon and rectal health, even in this day and age, doesn't get a whole lot of respect, in the lay press, we'll say. And the reason for that is because there's some barriers of talking about colon and rectal health amongst your family, your friends, and even your doctor. Some people are embarrassed to talk about all these things to them. And part of that can stem from, rectal exams. Somebody's gonna do a rectal exam on you, or pain. And then when people talk about colon cancer, they're like, oh my God, I'm gonna need surgery. And there's a lot of social stigma associated with things like colostomy bags, okay? So I think a lot of this sort of makes colon and rectal health not really well talked about in our society today because of some of these barriers. I'm glad that we have a whole month dedicated to us so that we can spread awareness of colon and rectal cancer. So March, again, is Colon Cancer Awareness Month, and these are the latest statistics from American Cancer Society. As of 2024. The data is, however, pre-COVID, so some of these numbers may change once we get the numbers in after all the COVID-related delays and things like that. It's the second overall leading cause of cancer-related deaths in the United States. It accounts for 8.6% of all cancer deaths here in this country. It's also the fourth most common cancer in the United States. So that's telling me if it's the second overall leading cause of death, it's a pretty deadly disease if you catch it. And it accounts for almost 8% of new cancers. It's estimated that last year, there was 153,000 cases that were people who were diagnosed with new colon cancers, and almost 50,000 people, or more than 50,000 people who died. So I've been through this for almost 2 decades now, and these numbers haven't really changed all that much. But there are some good and bad news, which we'll come to later. In 2020, almost right now, or we'll say in 2020, again, this is pre-pandemic, there's almost 1.4 million people living here in the United States with colon cancer. And the average American has about a 4% lifetime risk of developing colon cancer. And you're going to hear me talk about colon cancer, rectal cancer, and colorectal cancer interchangeably. I'm going to use those interchangeably throughout this talk, so bear with me. Here's the good news. Cancer rates have been decreasing over the past 3 decades. And I'm sorry for the small print here. This goes all the way back to 1975, and here we are in 2020. So as you can see, this is the death rate, and it's going down. And then the number of new cases is also going down. Okay? So, however, the other thing is the death rates have also, the survival has actually increased slightly between 1975 and now. I don't think they have any more recent data, but this most recent one I think is from 19. I'll have to look here too. Sorry about the small number. So colon cancer screening really got kicked into high gear when the colonoscopy was out. Before colonoscopy, people were doing flex sigs, and even before that, people were just checking their blood for checking their stool for blood, stool tests and things like that. But with the development of the colonoscopy, because a lot of colon cancers don't have any disease, so colonoscopy is one of those things. It's a good screening test. You want to have a low risk test that can detect something that's not giving you symptoms, and then diagnose the disease before it becomes problematic. So all of these gains is attributed to screening. And what's another great thing about colonoscopy is when they're there, they actually remove the polyps. And so I would say the vast majority, over 90% of colon cancer start off as a colon polyp. So by removing it today on a colonoscopy, it prevents that from turning into a cancer 5, 7, 10 years from now. So all this can contribute to our decreasing cancer rates. And then the other thing is the death rates decreasing and the improved survival can also be attributed to the early detection, and we have more systematic management of colon cancer these days. If you go to colon cancer here, if you diagnose with colon cancer here in Tucson, in New York, in Washington, D.C., in LA, in Seattle, you pretty much get the same type of care because it's standardized. You will get probably very similar chemo. The surgery will be pretty much similar throughout the country. And actually, I think that they're pretty similar all throughout the Western world as well. So by our better understanding of this disease process, I think that the treatment has also improved. The latest things that are on the horizon are like there's chemo that they give the chemo, or they give the treatment and they don't need surgery afterwards. So that's the exciting new step in terms of colon cancer treatment. Here's the bad news. So while we've been raising awareness of all the older population in our country, there still is a rising incidence of patients who are being diagnosed with colon cancer at a very young age, less than 45. 7% of all colon cancers are diagnosed in patients who are less than 45. And that's kind of scary. People thought that this could be, we're just not screening young people, and the older population is getting screened, so they're not getting. So we're just seeing a bigger percentage of the patients having colon cancer. But even taking that into account, there is a palpable increase in colorectal cancer in young people. And the other interesting thing is when they're diagnosed, they're more advanced at the time of diagnosis. So it's already spread to lymph nodes and maybe other places. I've seen colon cancer patients as young as 20, 25. That's very young. And so that's why about 5 years ago or so, many of you will remember that colon cancer screening didn't start until age 50. They lowered it to 45. So that's why a lot of the screening tests have now gone back to 45 because we're seeing this. And the trouble is we don't have a really good explanation of this right now. Also, what concerns me is that during the pandemic, we've had a pause in screening. Nobody was getting anything done. And so it's possible that in the next couple of years, we see an increase again in the rate of new diagnosis and advanced diagnosis, advanced stage at diagnosis. So there is a very big difference in terms of their survival with respect to what your diagnosis is, what your stage of disease is at diagnosis. So localized disease means that colon cancer is just confined to the colon and rectum and had not spread to the lymph nodes that live nearby. Regional means that they have spread to the lymph nodes nearby, and distant is when they've gone elsewhere. Usually your liver, your lung, occasionally could be your bone, your back, and things like that. So this is from, this is 2020 data. So about a third of patients will be diagnosed with localized disease, a third of patients with regional disease, and about a quarter of patients will have distant disease, and the rest they didn't really know, okay? So you can see the dramatic drop-off in the survival of patients who are at diagnosis depending on how advanced your disease is. And so this makes it even more important to get diagnosed early. What are the risk factors that we look at when it comes to seeing a new colon or rectal cancer patient that we see in the office? So who gets this? Now, males tend to get it more than females. Non-Hispanic, American Indian, and Alaskan Natives, African Americans. So these are the race of the patient and the gender who get worse disease at diagnosis. It's also more common. It's about almost a 2-to-1 male to female proportion. Caucasians are actually at less risk than average, okay? Median age, again, is 66, but like I said, this has been, pretty steady, but the rate of patients who are getting diagnosed less than 45 is it's going up significantly. And the median age of death is about 72. Inherent factors. So these are factors that you can't change. So your genetics. So you can't change that. You're born that way. So strong family history. If you look in your family history and Uncle Bob, your grandma, and multiple family members in different generations with colon cancer, you need to be worried that you are also at inherently higher risk. There's also certain cancer genetic syndromes, and a lot of these deal with colon cancer and colon polyps, but actually some of them are syndrome involving other cancers. You may have heard something called HNPCC or Lynch syndrome. There's an association with ovarian and uterine and some pancreatic and other things that, when you test positive for this gene, you need to be worried that you have a 50 to 80% chance of developing a colon cancer. I just saw a patient today who had, I believe, 20 polyps by the time he was 60. And that patient did not have a family history, but I'm sending him for genetic testing because depending on those results, if he was positive for this these cancer genes, then he needs to be tested, all his family needs to be tested, and his children, because it would affect when they get screened as well. And then there are other general things like inflammatory bowel disease. So if you have Crohn's or ulcerative colitis, these things can also, if you don't have good disease control, can put you at higher risk for colon cancer. So a lot of these you can't really change, but it's good to be aware of it so that if you're at a high-risk population, you will be surveyed and checked more often and earlier, starting earlier. Lifestyle factors. These are things that you probably can change. And smoking is one of the big ones. And in this country, the rate of smoking has decreased. But this is a strong determining factor. Sedentary lifestyle is another one. And this goes hand in hand with obesity. The World Health Organization actually categorized processed meats, so like deli meats, hot dogs, that kind of stuff, as a carcinogen, because there's a strong association of these things, these type of foods, to colon cancer and polyp formation. And the last is alcohol. Excessive alcohol use can contribute to an increased colon cancer rate. When I'm talking excessive, I'm talking more than 3 drinks a day, or 3 or more drinks a day. So basically, what you can do to reduce your risk of colon cancer would be to basically go the opposite of these things. So that includes avoidance of sedentary lifestyle, maintain a healthy weight, plenty of exercise, eating less, or eliminating processed meats from your diet. There's another thing that's coming out in the horizon, is that there is a possibility that processed food in general, simple refined sugars, those type of things, can also contribute to your risk of developing a colon cancer. Obviously, quit smoking and reduction of alcohol use. However, I'm here today to talk to you about the #1 way to prevent colon cancer, and that is screening. Everything is about screening. And I can't stress enough that a lot of times patients come to me and say, yeah, there's nothing wrong with me. I don't have a family history. I don't need to worry about this. They're dead wrong. And the reason is because I would dare say most patients will not have any symptoms. Now, they will have a lot of symptoms. Unfortunately, they can be sort of attributed to other things. Let's say you had new diarrhea, new constipation. Oh, I just had some bad food last week. Okay, if it goes away, fine. But if it persists, you need to have that checked out. Rectal bleeding, especially in young people. Oh, it's just hemorrhoids. No, it might not be. And especially, it would be a shame to miss a diagnosis because someone is afraid to go see their doctor and talk to them about this. So again, we talked about the lack of specific symptoms for colon cancer, but I'll tell you what the main ones are. Rectal bleeding, sometimes abdominal pain, change in bowel habits. Those are the big 3. And, but frequently I will see patients who don't have these symptoms and unfortunately get diagnosed with colon cancer. It takes a long time for a cancer to develop. They've done many studies before. Usually it's exposure of your colon lining to different kinds of carcinogens, and then it becomes a polyp. And then the polyp continues to get exposed to those carcinogens, and then it develops into an advanced polyp and final cancer. So this is the theory, is that it takes about 8 to 15 years for something from a piece of colon cell to turn into a cancer later on. And the thing is, with colonoscopies, you can eliminate polyps, so then it removes the chance that turns into a cancer later on, and allows for early detection of cancers. There are myths about colon cancer. Like I said, I don't have a family history, so I don't need one. Well, 5 to 10% of all colon cancers are associated with a family history or the genetic problem that we're dealing with. So the vast majority of colon cancers don't have a family history. I do not have rectal bleeding and my bowel habits are fine. Well, 30 to 40% of colon cancers have no associated symptoms. So that's kind of scary. So these are the guidelines set in this country right now. First colonoscopy, age 45, and this is for the average risk patient. No family history, never had polyps before, don't have inflammatory bowel disease or Crohn's or the other high risk things that we had talked about before. If your family history is positive, then first at age 40 or 10 years before the youngest affected family member. Now, there's one caveat here. When I say family history, I mean first degree relative, okay? Or maybe, and in some cases, we would consider second degree relative. So if it's your distant third cousin, Molly, that doesn't count, okay? It's your mom, your brother, your sister, or your children. Sometimes children get diagnosed first. I've had that too. And then they go get colonoscopy after their child was diagnosed with colon cancer. So, and then some of the family syndromes, you need to get started at a younger age. Some of them start as young as 20, 25 for some of the polyposis syndromes. All right, so we got to talk about the prep. Every colonoscopy, we have to talk about the prep, okay? How many of you here have had a colonoscopy before? Okay, very good. I'm just preaching to the choir, I guess. Anyways, and did you guys get the gallon? Okay.
I got a flavor.
You got a flavored one.
It wasn't.
Okay.
It was just a small, just one bottle.
Okay. All right.
What
So,
about the capsules?
yeah, I'll get to that.
Okay, good.
So this is what the first colonoscopies 20 years ago, that's what they prepped. So the colonoscopy itself isn't scary, okay? Because these days it's done under anesthesia. And so you don't have pain, you don't have any of that. And so this is still, we can't change this. You still have to give yourself, because we have to clean out the poop that's in your colon, so we can see little polyps in there. So this, unfortunately, will always remain a mainstay these days. This is the pill. So today, you can now you got to take 24 pills, okay? It's actually split in half. You take 12, and then you take 12 like 12 hours later. But you also have to chase it with 96 ounces of water. So, I mean, I don't know. I had this for mine, okay? My wife had this, and this was really nauseous. I tried it. I was like, I'll take this, okay? And some people actually even do it as simple as just an 8-ounce bottle of Miralax and 2 quarts of Gatorade. This just tastes like Gatorade. Of course, you have to maintain adequate fluid intake. So depending on your doctor, they will pick the appropriate one for you. But unfortunately, we can't change anything about that. You still need to have that horrible night, the best day ever, we say. Best night ever. This is what a typical colonoscopy looks like. It's a TV screen. The scope is right here, this black little thing. There's a back table. And the patient's bed usually is right next to it. And then your butt, your anus is sort of pointing towards the machine. And then we insert this long scope into you. Now, obviously, we wait until you're asleep. But we actually do some of these type of things in the office without any sedation. It's called Flex 6. And that's what people used to do many years ago as a screening test. But the problem with the Flex 6 is it doesn't go all the way around. It's much shorter. And for you to get all the way around, you actually do need some sedation. So what are the possible results from your colonoscopy? It could be normal. That's great. If you're average risk, we'll go over what happens to you next. You could see polyps. And again, there are different kinds of polyps. You might see the word hyperplastic. These aren't usually precancerous, although some people would consider them. Adenomas are the precancerous ones that we worry about. And usually these are, again, removed. And then they're removed so that they don't have a chance of turning into cancer later on. 25 to 40% of all Americans with over 50 have adenomas. So this is a very common thing. Just because you have one doesn't mean that, oh my God, I'm going to get cancer. Again, that's why the gastroenterologist will have you repeat the colonoscopy in 5 years, just to make sure nothing else grew back. And then the last one, unfortunately, is cancer.
What's the live or usually the live?
Oh, year old. I'm sorry.
What's it be?
50-year-old.
Oh.
That's just an abbreviation. I apologize. So this is what happens when you do a colonoscopy. All right. This is a polyp. And then we often snare it. So there's a little lasso that goes around it. And then we burn it and we just basically snip it off. And then the important thing is we retrieve this and send this to pathology. Anything that they remove, they will send to the pathologist to make sure there's not a cancer in there, a precancer, or advanced precancer, or just a normal precancer. Even if you had a cancer in here, if it's caught early enough, you don't need surgery to remove that part of your colon in certain circumstances. So that's why colonoscopy is so great, is because sometimes that's it. You can even avoid surgery sometimes. This is for a bigger cancer. This is cancer in the rectum here. This unfortunately will require a removal of the colon here, and then we'll remove this and then hook you back up. It's done these days with the robot. I do these all the time here at TMC. And it used to be, people stay in the hospital for 2 weeks and stuff like that. We have patients going home 3 days after the surgery. You still need to stay because we have to make sure that the bowel's open and things like that. And patients sometimes are back at work at 2 or 3 weeks because it's minimally invasive. But this, we want colonoscopies, hopefully will prevent you from getting to here. Okay. Other colonoscopy findings you'll see on your report. Diverticulosis. Most of these don't cause any problems. Almost only one out of 4 or 1 out of 3 will either end up in bleeding or something called diverticulitis. A lot of people confuse this with this, the itis versus the osis. The osis are the pockets that exist in your colon, and the itis is when those pockets get inflamed and you get an infection. Sometimes you might need surgery for that, okay? But just because like I said, the vast majority of patients who have diverticulosis don't have a problem, don't even know they have it. So they can either, and then if they do, it's either going to be bleeding or diverticulitis. And finally, we're going to be looking for colitis, okay? And that's going to be like Crohn's disease or ulcerative colitis. But there are other things that can give you colitis. Infections. Have you guys heard of C. diff colitis? When you take antibiotics and stuff like that, well, that's an infection. You can also get colitis from Campylobacter, bacterial things. You can get it from CMV. Anyways, those are other things that you might find on your report. Another thing that can cause colitis, before I forget, is taking too much NSAIDs. Okay, so
Taking too much?
NSAIDs, like aspirin and ibuprofen and stuff like that.
What's too much?
I don't know, just too much. So after you get your colonoscopy, you should get some sort of idea about when your next one is for screening. Okay. So if you're normal and low risk, no family history, nothing like that, 10 years, it's going to be your next one. If you're at higher risk, it could go down to 1 to 5. Let's say your mom had colon cancer. Well, then you're going to be on the 5-year plan. If you yourself had colon cancer, you could be on the 5-year plan. Previously, that is. And then, so make sure when you get your colonoscopy report, it says it on there when you're going to need your colonoscopy. The difficult question these days is, when do you stop needing to get colonoscopies? The current guidelines say 75, but because people are still living longer, and so it becomes a case by case thing. You need to talk to your gastroenterologist. Certainly, if you have at least 10 years in front of you because you're healthy, you have a good heart, you don't have any medical problems, I don't think getting another colonoscopy in 10 years at 80 is that big of a deal. It depends on, it's a very case-by-case basis, okay? But a lot, right now, I think a lot of people are getting cut off at around, I think 80 or 77 or 79, even though the official guidelines say 75. So, but here's the thing. The other day, we saw a patient at TMC, 97, first time colon cancer. His last screening was at age like 80. What do we do about that? I don't know. But I will get to what might have prevented that case, okay? This. So, even though we stopped screening, even if we followed the guidelines to the T and stopped screening at age 75, you should be able to get a colonoscopy anytime to see what is wrong. So, you have change in bowel habits, and this could be subtle for patients, but new diarrhea, new constipation, mucousy stool, just things are different. Or your stools are getting skinnier because whatever this cancer or this polyp is starting to basically narrow the lumen or the opening in your colon, so your stools are getting smaller. You know, these things are things that warrant some further investigation. And the only way to do it is through the colonoscopy. So even if you're 94, 95, if these things happen, wouldn't you want to know what's wrong with you? So I think that's where the colonoscopy will still come in, even though you're past the age of screening, we'll say. Screening, for me, is a definition for patients receiving a colonoscopy who have no symptoms whatsoever. Fine, I can't convince you to get a colonoscopy, all right? We have a lot of these patients around, especially younger people. So it used to be we would get stool-based testing, and they would look for blood. They were notoriously not very accurate because if you ate a bunch of beef the day before, the heme and the beef would maybe show up as a false positive. It's gotten more sensitive, but a newer test came out on the market, which is called Cologuard. And this is looking for cancer DNA. So they look at your stool and actually look for DNA changes that represent cancer. So this is a pretty good test. It detects 92% of colon cancers and a lot of precancerous polyps. So I feel like for the people who are really nervous about getting a colonoscopy or just don't want to be bothered by it, this will afford better screening to other people. This is what's inside your kit. Comes with a box, a container, this spatula-looking thing, and then this solution. So the way they do this is this fits on top of your toilet seat, and then you put the little container right here in the middle, and you poop right into it, okay? And then afterwards, you got to get this little proby thing, and you scoop. You get like a little scoop. It's very small. It's basically this big. You scoop it out, and then you put it in a little test tube, and then you pour the rest of the preservative fluid in here. The box, before you're ready to use it, is stored in the refrigerator, but when you're done, you're not supposed to put it back in the refrigerator. All right? You're supposed to send it through UPS or whatever, and then they come and pick it up, and then the next day, okay? And they send it off, and you should get a result in about 2 weeks. Again, now that it's been screening now down to 45, you can start doing this at 45. I'm getting this all over my Facebook, like those ads. I keep getting these, even though I already had a colonoscopy. But if it's negative, the difference between this and colonoscopy is you need to do it again in 3 years, okay? And if it's positive, you still really need a colonoscopy to see what you have. But I think this is okay because for some people who don't want to get a colonoscopy because they're afraid of it for whatever reason, well, this might force them to say, yeah, there's something wrong with me. I need to go get my colonoscopy. So we talked about symptoms: bleeding, abdominal pain, diarrhea and constipation, and change in bowel habits. I believe abdominal pain and bleeding are the most common. They're about 30%, in a recent study. I actually find that it's more this or this, because, and I don't know if it's because I'm a colon specialist, and then somebody comes in to me to talk about hemorrhoids, and I was like, actually, I'm really worried about what you're telling me, that you actually have a colon cancer or rectal cancer. So again, you could have these symptoms, but that's beside the point. You still need screening.
So which two were you worried about, the diarrhea?
Yeah, I feel like these two are more worried, although the studies seem to say it's these. But abdominal pain, that's such a vague thing. Everybody can have, abdominal pain. All right, so that gets us to the bottom of the talk. Basically, I went over prevention of colorectal problems is basically healthy lifestyle, high fiber, and just do the colon screening. Okay, just do it. And then if you have symptoms, ask somebody. Don't be afraid to talk to your doctor. I'm surprised at how many patients who come to me who said, "Yeah, I don't want to go see it. I don't want to tell my." They're embarrassed by talking to their family doctor about this stuff. It's their job, okay? And they are more than willing to send you to come see me or see a gastroenterologist for their treatment. I guess we can open up the questions right now.
So thank you so much, Dr. Lee. I do have quite a few questions that have come in and that we'll tackle right now. So one question about a colonoscopy is, does it also detect anal cancer?
Okay, so it can, but the problem with anal cancer is the way that a colonoscopy works is you blow air and the colon distends or gets bigger inside, okay? It's like a balloon getting bigger because they're blowing air in there. When you do that, then the wall stays behind and the things that are sticking out, like polyps and cancers, are sticking out until you can see them. In the anus, it's a very strong muscle. Everybody's anus is very strong, or else you'd be leaking poop all the time, right? So the air can't distend that. So, but the thing is, a rectal exam can do it for you. Your finger is, at least I find that my finger is more sensitive to detecting abnormalities in the anal canal than an anoscope, because I could feel it. Our sense of touch is very, very sensitive. So while this is another thing, is I don't know, I feel like as time goes on, less and less people do rectal exams anymore. And that includes if you show up at the ER with rectal bleeding, they don't do a rectal exam anymore. And I do it, I was like, oh my God, there's a cancer right here, or whatever, So I feel like that could be part of, how people are treating patients these days. But I think if you're looking for anal cancer, the most sensitive test is a finger exam, a rectal exam, or an anoscopy. And if you have a good family doctor, or an old-fashioned family doctor, they will do it. I just find that maybe that's becoming maybe a lost art, and they're not doing it as much. So, I still think I don't think a colonoscopy might detect it, but I don't think it's the best test for it. And another caveat is Cologuard does not detect anal cancer. It does not detect anal cancer. It only detects colon cancers such as adenocarcinomas. There are other types of colon cancers that are much more rare, which are not detected on Cologuard, but maybe detected on colonoscopy.
And speaking of Cologuard, are there instances where there are false negatives then? It sounds like maybe, right? A false negative reading, so that it's saying you don't have anything, you don't have cancer. Is that a big percentage of what comes through on Cologuard or not? I know you mentioned, I know that oftentimes false positive.
Okay. So I've dealt with a lot more false positives than false negatives. I can probably think that there were, I think 2 or 3 in my 15 years of doing this, and Cologuard's been around for about 5 to 7 years, okay? I've seen only 1 false negative, but maybe 1 or 2 dozen false positives.
Okay. Just just so that we understand. Now, another question was regarding on the PrEP. So the new pills that you can take now with what was it, 24 ounces of, or it was 24 pills, right? With 96 ounces of water, if I'm not mistaken. Yeah. Are there any long-term side effects taking the pills if you were having regular screening, these colonoscopies, with this type of PrEP?
I don't think that, so when you're taking the pills, I don't know. I personally tried them. But I didn't use it for my colonoscopy. I did this from personal experience. They just caused so much nausea to me. It just tasted really bad. Okay. I don't think that but my wife tolerated them okay. And I know a lot of people who do it. One barrier for the pill could be your insurance. I believe it's like $125 on a lot of insurance plans. Whereas this is usually free. I don't think there's any long-term effects. Obviously, if you take this all the time, you can be dehydrated and have electrolyte abnormalities and go into kidney failure. But that's that's only if you're taking it every single day, for a long time. For the purpose of the colonoscopy, I'm not sure that it causes any significant side effects.
So if you were having a colonoscopy every 5 years, then you wouldn't have to worry. You wouldn't necessarily need to worry about that. Okay. And that's sort of what I was, trying to get down to is I've heard that there may be some side effects.
Mm-hmm.
I also wanted to ask about the BRCA gene. So if somebody has the BRCA gene, my understanding is they do have a higher genetic. Is that correct?
BRCA
as well.
BRCA2.
Okay.
And there's also some association with HER2 as well. Although we don't routinely test it for these right now, colon cancers, but there is also some HER2 association too, and how that affects.
And is it only BRCA2? Is it only BRCA2, or is BRCA1 also another?
I'll have to go back and look it up, but I'm pretty sure BRCA2. I'm not totally sure about BRCA1.
Okay. What about, so if somebody has a strong family history of cancer, colon cancer, pancreatic cancer, and they're already 75 years old, and they've been getting screened every year, would there be a reason at this point that they should also get genetic testing? Sounds like maybe they might want to continue with at least getting screened every 5 years.
I think that for that patient, that becomes a discussion between the physician and the patient. I think that if the patient had no children and no other relatives, they may say, I don't want to keep going. I don't want to know. Okay. However, if they have children, that has implications on their children's health. So in that situation, I may urge them, to consider it strongly for genetic testing, because that has implications to somebody else.
Okay. Sure. And if you have a vegetarian diet, I know you talked about processed meats. If you're a vegetarian, does that decrease your risk of getting colon cancer, or?
It does, except that you may not notice a huge difference. These differences are found in large population studies. So it may be only like fractions of a percent, but it's still statistically significant. So therefore, it's reported.
Great. Okay. So those are the questions that I have. I do want to share, if anybody is interested in an appointment, where do they call? So the number is running on our screen right now. It's 520-416-5700. You can also reach out to Arizona Oncology by visiting their website at arizonaoncology.com. I want to thank you so much for being here, Dr. Lee. This was great. I'm glad that we were able to highlight this, particularly during, colorectal cancer month. And I hope that everybody goes out, they get their colonoscopies taken care of, and stay healthy. And I'm going to turn it over to our in-person audience so they can ask you any questions, but I'm going to close it up with our online audience. Thank you so much for being here today.
Thank you for having me.
So thanks again for joining us. We are going to be resuming with our next talk, which will be memory and aging. How does it change? Why and what can be done about it? That's on Thursday, March 28th at 10 a.m. If you're interested in this class, please give us a call in the office. The phone number is 520-324-1960. Thank you.